All right, so we were wrapping up on cranial nerve number 8. Listen up, hearing. So focusing on the hearing aspect. So there is a quick screen you can do in the clinic that can be helpful for understanding the difference between. We talked about conductive hearing loss versus sensory neural hearing loss. So the conductive hearing loss is when the external auditory meatus, the canal is blocked, and that sound waves can't actually get into the cochlea. Okay. Sensory neural loss is where the cochlea itself, the receptor cells, or the nerve is damaged, and so the sound waves get in, but they can't get translated. Okay. So a way to kind of screen for this is a couple tests. There's the Weber's test, which is you're seeing an example of here, and Renee's test. So Weber's test, this is the principle behind it. So if you look on your left, starting with normal, if you have normal conduction and sensory neural, you should, if you do this screen, so you tap on your tuning fork, typically use a 512 for this, not a 128, but you guys can use a 128. And you place it on your vertex of your head, and you should actually hear that sound equally. You're hearing it, but it's because the bone is vibrating and stimulating actually the nerve itself or the cochlea without actually sound waves. So if you're normal, it should sound like it's coming from the center of your head. You should hear it in the center of your head. So try it if you want to. Do you get a sense that you kind of hear it and you feel the vibration in the center of your head? So it's being distributed or picked up equally on both sides, okay? If it's a conductive loss, okay, if it's a conductive loss, what'll happen is you'll start to notice the sound greater to the same side as the conduction loss, because when you have a conductive loss, you no longer have any interfering outside noise. So you actually hear vibration more on the side that actually has the conductive loss. So you blocked sound waves from getting in, but your cochlea and nerve are okay. And so what will happen is you'll actually perceive that the sound is coming more from one side. And the way you confirm that is then you take that off and you have it vibrating here. It's still vibrating. Then I go over to the ear itself, and it should be louder when I actually bring it up to the ear than what you were hearing here. If it's a conductive loss, what will happen is, so I place it on top of the head, and they go, it's louder on the left. And then I go over here and they say, I can't hear that on the left. So it's because the sound waves aren't getting in, but the vibration is being picked up, and the vibration even seems like it's greater or enhanced because you don't have to compete with actually the sound from the external environment interfering with that vibration. Does that make sense? So it's kind of a unique kind of situation. If it's sensory neural loss, so you've lost the nerve or the cochlea itself, what will happen with that is you place it on top of the head, okay, and it'll sound louder on the side that is normal. You won't be picking up the vibration because the nerve itself is damaged. And then when you bring it off to that side, it's actually also impaired as well. The sound gets in, but it can't stimulate the cochlea or the nerve. So you have both loss of the vibration sense or hearing of the vibration plus loss of the ability to hear on the outside. Okay, does that make sense? So that's kind of how you screen between normal, conductive, and sensory neural. You can do kind of the same with now Renee's test is what you do is this. You go and you touch the mastoid process, okay? Now what should normally occur is they should be able to hear that vibration, and then you hold it there, and once they no longer feel the vibration or hear it, then you bring the tuning fork again to their ear, and they should actually still be able to hear that. So this tests the conduction, not conduction, this tests the vibration of the sensory neural component, and then conduction is actually usually better. The conduction, if you have normal conduction ability, the normal avenue that sound waves get in there is better than just vibrating the bone. So if you bring it up here, you should still be able to hear it. So what you do is you start on the mastoid process, okay, I hear that. Then once it goes away, so that checks my sensory neural, and then I bring it up to here, and I still hear it. It's nice and it's actually louder than what I sensed here. So that's normal sensory neural and conduction. If they had a conduction loss, you'd say, oh, I hear that. That sounds, and then you go here and they don't hear it, or it's less than this, okay? That's a conduction loss. If it's a sensory neural loss where the nerve itself is damaged, they go, I don't hear that, and I also don't hear that. Okay, so both are impaired because you've actually damaged the nerve. So anyway, you can do that as a quick screen with a patient if you need to. The other way we do it, you know, is real simple, is just you take your fingertips and you rub them together and you say, I'm going to rub my fingers together, and I should usually do it one side at a time. Tell me when you can hear my fingers. You got to do it in a quiet environment. That's the hard part about this stuff. And you just rub the fingers, and then you kind of sense when they hear it. You do the same on the other side, and you can just judge the distance, and that's just your quick cursory screen to see if the patient's having some hearing loss enough to impact, you know, whether you're trying to give them instructions or safety and those kind of things. So lesions of cranial nerve number 8, if you've got damage to it, lesions can cause vertigo, okay, the vestibulocochlear nerve, deafness, if it's the actual nerve itself, okay, and or a combination, okay, combination of vertigo and deafness. There is a very common type of tumor that's associated with the vestibulocochlear nerve called an acoustic neuroma. It's a schwannoma. It's the Schwann cell, those myelin Schwann cells on that peripheral nerve that actually are where the tumor develops from. And it's the most common tumor of the cerebellar pontine angle, okay? So that there's an angle there between the cerebellum and the pons, where the cerebellum and pons come together. So that is this, the region of the cerebellar pontine angle is this region right in here. Cerebellum, pons, they're kind of this junction point. That's a cerebellar pontine angle. So here's a very large schwannoma that's affecting cranial nerve 8. Oftentimes, if it's big enough, it'll affect cranial nerve 7 too. So they might start out with some subtle dizziness, hearing loss, then they start actually getting facial involvement and droop and those kind of things. And this is just showing you on this slide here is you can see the tumor actually going in and invaginating through the little opening here in the skull and compress on the nerve. And it can press on more of the auditory. It can be more involved with the auditory or the vestibular part or both. So it just depends on the presentation. So those are benign, okay? These are not typically metastatic or malignant in nature, but they can obviously be a problem if it stays there and gets too big. So they have to take them out. And then depending on how it goes when they take it out, they sometimes can lead to some damage of that nerve. And then you will see patients, especially if you work in any kind of vestibular practice, with doing rehab after that particular surgery, after that removal of a schwannoma, acoustic neuroma. Cranial nerve number 9, glossopharyngeal. All right, so you see it there on the diagram. Mixed nerve. So this is mixed, mostly sensory, has the biggest component of that. So sensory of what? Of the soft palate, so back of the throat, the pharynx, and it's also taste for the posterior part of the tongue, and does bring in some visceral sensory, so helps manage some of our autonomic function through its bringing information from the carotid sinus and body, okay? It does have a small motor component, so just motor of one little muscle, the stylopharyngeus muscle, okay? It has a parasympathetic component, okay? So the parasympathetic, that autonomic efferent parasympathetic component is to the parotid salivary gland, okay? So help for salivation. It is considered the afferent part of our gag reflex. That's that sensation of the soft palate. So when you're touching the uvula or the back of the throat, that cranial nerve number 9 is what sends that, you know, sensory information into the brainstem. Because it has mixed functions and has all these different functions, it actually has a number of nuclei associated with it. So we've seen this one before in other cranial nerves, the salivatory nucleus, which is going to supply that parotid gland. It has the solitary nucleus, which is a sensory nucleus, in this case for taste, from the taste, that posterior part of the tongue. The motor component of it, the motor to the stylopharyngeus muscle, the cell bodies for those are located in what's called the nucleus ambiguus, okay? And then the spinal, this is interesting, is that it actually, the sensation for the soft palate and pharynx are actually sent to cranial nerve number 5's nucleus. So it's the spinal nucleus cranial nerve number 5. There's another reason why it's so big. You know, it's bringing in not just information from cranial nerve number 5, but it's processing information from cranial nerve number 9, okay? So that's just showing you the approximate location of those nuclei that are associated with it and then their innervation. Lesions. If you have a lesion, you will lose your gag reflex, okay? If the lesion is just on one side, you're going to lose, you'll still have it on the one side of the back of your throat, but the one side will be impaired. So if I have a lesion of the nerve on the right side, I'm going to have, if I touch the back of my throat on the right, I'm going to have a loss of my gag reflex, okay? And that can be a problem for your patients. If you don't have a gag reflex, you tend to swallow liquids, and they tend to go right on down into the trachea and give you pneumonia and those kind of things. So you want to have an appropriate gag reflex, okay? It can lead to difficulty swallowing because you need good sensation in the back of your throat for normal swallowing mechanics and coordination of swallowing. So that can be a problem. And also can lead to decreased salivation because of that innervation of the parotid gland. Cranial nerve number 10, vagus. In your edition 4 of Lundy-Ekman, they have a, I think it's figure, what chapter is it? 14? What chapter is that in? I forget what it is. But there's a figure on there where they have it wrong. They actually are showing you cranial, they mix up cranial nerve number 12 and 10. So they show it looking like it's cranial nerve number 10, showing you that, but it's actually cranial nerve number 12 that should be. Let me just see here. Cranial nerves, it is figure 14, 17. They show this, you'll see it, you have to look at it, but they show that as cranial nerve number 10. That is not cranial nerve number 10. So this is correct, what you're seeing here, which would be this guy right there, okay? So another mixed nerve, okay? Sensory and motor of the larynx, pharynx, and visceromotor, okay? So the visceromotor is really the parasympathetic, right? The sympathetic and parasympathetic are efferent parts of our autonomic nervous system. So this is the parasympathetic drive to a large region of our viscera, but also the larynx, pharynx, and trachea, okay? And then lungs, heart, gastrointestinal tract, pancreas, gallbladder, liver, so a good portion of our viscera. Parasympathetic control is through the vagus nerve. It's also the efferent component of the gag reflex. Because of its motor innervation of the larynx and pharynx, you know, the glossopharyngeal is the sensory part, but the vagus is where you actually, the motor part of that gag reflex, okay? And because it's mixed, it also has multiple nuclei associated with it. So we've got the dorsal motor nucleus of cranial nerve number 10. This is the visceromotor or visceral efferent. The nucleus ambiguus is what supplies the somatomotor part, not the visceromotor, but the actual muscles of the larynx and pharynx that are driving the gag reflex and coordinating swallowing and those kind of things. So that's the somatomotor, not the visceromotor. And then it also uses the solitary nucleus. Keep seeing that solitary nucleus pop back into play here. That's where sensory information from the viscera comes in to be processed to help guide the autonomic response and control, is through the solitary nucleus. Just shows you again the general locations of those nuclei situated in the brainstem, which we'll get to see here shortly in cross section, and then the muscles. So if you got problems with either 9 or 10, you have some difficulty with speaking or swallowing, because those are what are used for sensing the throat area and controlling muscles of swallowing and speech, okay, at the actual, within the throat and larynx and pharynx itself. You will often have a loss of gag reflex. You may actually have poor digestion ability. The parasympathetic innervation for digestion can be impacted. And you may also note asymmetrical elevation of the soft palate, okay? Because that's what, when you go, ah, and you have somebody do that, you would normally look in the back of somebody's throat and you see the soft palate elevates equally on both sides, and the uvula goes up symmetrically, okay? Goes up at the same, in the center, okay? If somebody has a problem with the cranial nerve number 10 on one side, so if my right cranial nerve number 10 is impacted, and I tell the patient to go, ah, my soft palate on my right will not contract appropriately. So which way is my uvula going to deviate? When I if it's a right-sided cranial nerve problem, which way is my uvula going to deviate? It's going to go to the left because the left side is going to elevate more than the right, so it's going to pull the uvula over to the left. So if your damage or lesion is in the brainstem affecting the cranial nerve 10 nucleus or the nerve on the right side, the uvula, when they go to ah, it'll deviate to the left. So it'll deviate contralateral to the lesion if it's actually impacting the nerve or the nucleus. However, if somebody has a stroke that involves the left side of the brain, that's this cortical bulbar tract that goes down to tell that cranial nerve number 10, when I voluntarily go, ah, if that signal can't tell the nucleus and the nerve to send that signal, then the uvula, it deviates to the left, so it deviates to the same side as a cortical bulbar tract or lesion of the upper motor neurons that send the signals from the cerebral cortex down to the cranial nerve nucleus and the nerve. Does that make sense? So if it's in the brainstem, the lesion is in the nucleus or the nerve, the uvula would deviate to the opposite side or contralateral to the lesion. But if it's in the brain, internal capsule, any of the pathway, the cortical bulbar tracts that go down to tell that nucleus what to do, then it's going to deviate ipsilaterally to the same side as the lesion, okay? Now we're on number 11, spinal accessory nerve, okay? Pure motor, pure somatomotor, innervates just striated muscle, SCM in the upper trap, okay? So you guys have already learned how to test this, manual muscle tested, all that good stuff. The cell bodies for it are actually down in C1 to C4, okay? So it's actually down in the cervical spine. The nuclei of cranial nerve number 11 is called the spinal accessory nucleus, and we see this in C1 to C4, this nucleus that extends down into those regions. So here it is, right here, innervating those couple muscles, upper trap and SCM. It's got a pretty interesting course, actually. So if you look at, here's a good old Netter picture here. If you look at the green here lines, this is the innervation of C1. Some people say C1 to C5, mostly C1 to C4. Those exit out of the spinal cord, ascend up through, this is the bottom of your skull here I'm outlining. It ascends up through the foramen magnum. So it actually goes up and then comes right back out the jugular foramen and then goes down to supply. So they call it a cranial nerve, but it's really like a cervical nerve. It just happens to get up there into the cranium. It goes into your skull, but it starts lower in the cervical nerves, you know, as a C-spine origin, but actually goes up into the cranium. So that's why it's still kind of called a cranial nerve. And then but it exits right back out. If you have lesions of that nerve itself, if you avulse it or compress it or something like that, you're going to have ipsilateral paralysis or weakness, okay, of the upper trap, if it's a lower motor neuron problem. If it's an upper motor neuron problem, you don't have a lot of pure weakness on one side. You don't have a lot of hemiparesis or one-sided weakness because this is innervated a lot by the medial activating system, so you get more bilateral connections of these proximal muscles. So if you've got somebody who has a stroke that involves cortical spinal tracts, you may have a little weakness on one side, on the opposite side, contralateral, but it's not going to be super profound because you've got more bilateral connections from the medial activating system. But if you damage the actual nerve that's going to the muscle, that final common pathway, and damage the nerve, then you can have pretty profound weakness and atrophy and those kind of things. So upper motor neuron versus lower motor neuron. Lower motor neuron, ipsilateral weakness that's profound with atrophy. Upper motor neuron problems, some weakness contralaterally to the lesion, but not too bad. 12, last one, hypoglossal, okay? So here's hypoglossal right here. Pure motor, okay? Tongue muscles. Has both voluntary, you can stick your tongue out when you want to at somebody and make your tongue do rolls and flips and all that. Some of you can anyway. It also has reflexive circuitry that are involved with just basic, swallowing mechanisms and so forth. So there's the cell body, or the nucleus, and you've got one on each side. All these cranial nerves are paired. If it's a brainstem problem, if the lesion is in the nucleus itself or the peripheral nerve exiting out, you're going to have weakness on one side. So the way I can, if you look at this, if a person, you ask the person to stick their tongue straight out. So you ask them to stick their tongue straight out. If they have weakness on the right side of their tongue, okay? If they have weakness on the right side of their tongue, which way is their tongue going to deviate? If you stick it out, tell them to push the tongue out. If it's weak on the right side, and I ask them to stick it straight out, which way do you think it will deviate? It'll deviate to the right, because the left side is doing a better job of pushing the tongue out, and the right side's not matching it. So the left side pushes, and the tongue will turn to the right. It'll turn towards the side of the weakness, okay? If it's a lower motor neuron, the nucleus or the nerve, the tongue is going to deviate to the same side as the lesion, okay? So if you know the lesion is on the right, if it's the right hypoglossal nucleus or nerve, the tongue will deviate ipsilaterally to the lesion in reference to the lesion. If the lesion is up in the cerebral cortex, it involves the upper motor neuron that goes from the cerebral cortex down to the nucleus, then the tongue will deviate to the opposite side of the lesion. So it deviates contralateral to an upper motor neuron lesion. It deviates ipsilaterally to a lower motor neuron lesion, okay? This is from your neuroanatomy book, the Crossman book. This just shows you kind of a nice representation here. So on this side, on your right side, these are all your motor nuclei, okay, for cranial nerves, the motor components, okay? Then on this side is your sensory components, okay? So they're just highlighting only motor on one side and sensory on the other. We obviously have motor and sensory on both sides, but just kind of easier for you to appreciate kind of where these things are located in general. And you'll notice that in a moment here, when we start getting into cross sections, like right through here in the brainstem, that's where things get ugly, because you can see how many nuclei we actually cut through here in this kind of upper medulla area, is where we cut through see a lot of different nuclei in the upper medulla. So descending control of motor cranial nerves. So cranial nerves that have innervation from cortical bulbar tracts, that have some voluntary control over, that's what we're talking about here, the descending control from our cerebral cortex for voluntary control of these. So these are via a couple pathways. The cortical bulbar tracts, okay? So remember, like, we have these tracts that run from our cortex that are cortical spinal, cortical bulbar, cortical limbic. These are tracts that are running from our cortex that go down to either the spinal cord or the cranial nerve nuclei to innervate those lower motor neurons in the anterior horn of the spinal cord or in the nuclei associated with cranial nerves, okay? Most cortical bulbar fibers cross. So typically, if you have a lesion up in the cortex or in the cerebrum, you're going to have contralateral deficits, okay? So this is upper motor neuron type lesion, okay? If the lesion is at the level of the nuclei or to the actual lower motor neuron, the cell bodies in the nuclei or the nerve, that causes ipsilateral weakness to the lesion. Okay, this is all relative to the location of the lesion. So in the brain, if the lesion's on the left, it involves any of the cortical bulbar tracts that go down to control those cranial nerves, you're going to have right-sided problems. If the lesion is on the left in the nerve or the cell body in the actual brainstem, it's going to be on the same side as the lesion. It's going to be on the left as we're going to have when you're going to have the deficits. Ipsilateral weakness. So, any questions about cranial nerves? Because we're going to move right into brainstem here now. Yeah. She asked, is the nucleus in the brainstem considered upper motor neuron? No. Just like in the spinal cord, if you damage the cell body, the final anterior horn cell or lower motor neuron, that starts actually in the nucleus or in the brainstem nuclei for the cranial nerves. If it's a motor nucleus, it starts in that, nucleus, and the cell body there. If you damage that cell body, that's still considered a lower motor neuron. You have to impact or damage the descending pathway that's going to communicate with that to be considered an upper motor neuron. But it's kind of like this little gray area that's transitioning, even though it's still located in the spinal cord or still located in the brainstem. It's a lower motor neuron, but you got to get out of those to be called a peripheral nerve. So eventually that becomes a peripheral nerve, and that axon is in a peripheral nerve, but it actually starts in the nucleus itself. Yeah.
Do you consider the oculomotor nerve to just be motor?
The oculomotor nerve is primarily a pure motor. Yeah, it's got a little parasympathetic component. But yeah, it's mainly for driving movement of the eyes. Yep, striated muscles that innervate eye muscles. Get through. All right, so most of this stuff you've heard before at one time or another, except for when we get to the cross sections. But so some of this will be review. Brain, stem, medulla, pons. I'm sorry, midbrain, pons, medulla. Whew. Maybe a review for you, but not for me. All right. So this is showing you the front view, and this one's had pretty much everything cleaned off of it. Okay. The only thing kind of left on here, well, is this. Well, you can see this little trochlear nerve, tab end of a trochlear nerve, getting ready to come around the back side. Okay. This one here has a few more structures of relevance here. This is optic tract. This is the cut ends of the optic nerve. This is the optic chiasm. From the outside, we call these our cerebral peduncles, right? Okay. Here's the trochlear nerve right here coming around from the back side. They cut off on the other side. It's not there, but this is the trochlear nerve coming from the back side. This is oculomotor nerve right here. Coming out from this is that interpeduncular fossa. Here's our two mammillary bodies sitting right here. This whole front region of the pons from the outside like this is called the basilar pons when you're looking at it from the outside. K, this area right here is the basilar groove. This picture is from your lab manual book, okay? So this is the pictures you're going to see today are ones that would be the ones that you would see on the identification or lab test, okay? So when I do that and you see these slides, these are the ones you'll actually be seeing. I try not to pull anything out on you that you haven't seen before, okay? I do my best not to do that. And you'll see when we do the practical or practice test for that, pretty much you'll see most of the images that you would end up seeing on the actual exam itself, okay? So there won't be any surprises. This would be the abducens nerve. Oh, here's the cut end of the trigeminal nerve right here. Gets a little murky in here sometimes, but 6, then you'd have 7 is facial, 8 is vestibulocochlear. 9 and 10 are really hard to kind of pick up here. I think one of them has been torn off there. This is the spinal accessory nerve that comes up and through. And then you're seeing some little fibers here of the glossopharyngeal that they eventually come together to form the glossopharyngeal nerve. Okay. Pyramids, right there. And there's actually decussation of the pyramids is right in here. You can actually see here on this one, it starts to cross over here. And actually, if you take like a probe, and if you have a brainstem specimen, you stick the probe in this ventromedian little fissure here, and you drag your probe down. Eventually, you hit a spot where it stops, and you can't drag it any further. That's where those decussation, the pyramidal fibers, the cortical spinal tract fibers start to cross down the front of the brainstem. Okay. Here's our olives, inferior olives. So that kind of covers most of the main features there. And in the lab manual, I have highlighted or circled the structures that you need to know, okay, on any of the different diagrams. Backside, a little more scary. So here's our superior colliculus, inferior colliculus. This is the medial geniculate body. Lateral would be out here a little further, but this is where our thalamus is right here that's been cut off. The thalamus is sitting right there. And then our third ventricle is right in here between these two. This is called, this little guy right here, this is the brachium or arm of the inferior colliculus. That's where the fibers are. So when you get some initial auditory information that comes in, some of that auditory information goes to this inferior colliculus, and then that's relayed via the brachium of the inferior colliculus to the medial geniculate body. Then that goes to your cerebral cortex and gives you that some conscious awareness of where to turn your head and those kind of things towards that sound. This space right here is called the rhomboid fossa. So the rhomboid fossa is basically the floor of the fourth ventricle. We've taken the cerebellum off the back of the brainstem. When you have the cerebellum in place, that space between the cerebellum and the brainstem is the fourth ventricle. So when you pull the cerebellum off, this little rhomboid fossa is considered the floor of the fourth ventricle. Okay. Here's our superior cerebellar peduncle. This is our middle cerebellar peduncle, and this is our inferior cerebellar peduncle. Okay. This side isn't cut quite as well, but superior, inferior, because it extends a little bit lower, and then our middle cerebellar peduncles on this side. Back here we have our gracile and cuneate tubercles. Remember, these little tubercles are bumps, and you call them a tubercle if you're looking at the external surface here. So those are our, and underneath there is our gracile and cuneate nuclei, right? And then here's our, we divide this up, we can see kind of we have a center, sulcus there, and then we can kind of divide this up into these regions here. And so we have our fasciculus cuneatus, and then more medial is our fasciculus gracilis, okay? That's where our proprioceptive information is coming up the back of the brainstem. Pretty much the same things on the back of this particular brainstem. On the right side, yeah. So this would be the superior cerebellar peduncle, the inferior cerebellar peduncle, middle. Superior, inferior, and middle. The inferior is really not that much inferior. It's just it's below the superior, and then the middle cerebellar peduncles, more lateral. Okay. All right, so brainstem. We know we have a lot of nuclei in the brainstem, but we also have vertical tracts that run through. Some of those tracts run through relatively unaltered. They pass right on through to go down to the spinal cord, or they're going up from the spinal cord right on through to go up to the cerebrum, and they don't make a lot of connections in the brainstem. However, a fair number of these tracts make some connections in the brainstem on their way to and from, okay? So the ones that pass through relatively unaltered are the spinal thalamic tract, kind of runs up through the brainstem to the cortex, the medial lemniscus, the sympathetic tract, the dorsal and longitudinal fasciculus that goes from the hypothalamus down to the sympathetic nervous system that starts, in our upper thoracic spine and lumbar. That little tract runs down. It's a little tiny tract that runs down through there. And then also there's a kind of a parasympathetic equivalent. They don't really call it anything. They don't call it a dorsal longitudinal. There's a little parasympathetic tract that runs down through your brainstem, all the way through your spinal cord, all the way down to the sacral part of your sacral division of your parasympathetic nervous system to help drive or control that. Then also the corticospinal tracts. The corticospinal tracts are going down corticospinal. They're going to the spinal cord. Okay. Some have synapses within the brainstem. Okay. We have our spinocerebellar tracts, right? Even though the cerebellum is, sometimes they consider it functionally kind of part of the brainstem, so spinocerebellar tracts, they go up and they go into the cerebellum. They don't go through, pass all the way through the brainstem. They go up through most of the inferior cerebellar peduncle and then into the cerebellum. Cortical bulbar tracts. So the cortical bulbar tracts are those tracts that are going from our cortex to those cranial nerve nuclei, those motor nuclei, okay? Just like our cortical spinal tract goes to the motor nuclei, motor part of our limbs and our body, this is going to drive the motor part, especially the voluntary motor part of our cranial nerve nuclei. Corticopontine fibers. Corticopontine fibers, so all of these start together. They start in the cortex. You have cortical spinal, cortical bulbar, corticopontine fibers, and cortical reticular fibers that all are running together. The ones that pass through relatively unaltered all the way that go down to the spinal cord are the cortical spinal tracts. The fibers that stop in the cranial nerve nuclei, that's the cortical bulbar tracts. Okay? The ones that stop in the reticular formation to drive the reticulospinal tracts, those are the cortico-reticular tracts. And then there's also the corticopontine fibers that are all running with these two. They drop off their signal in the pontine nuclei, which then send it to the cerebellum to send that copy of the motor message that the cortical spinal tracts are carrying all the way down to the anterior horn cells. So then we have some vertical tracts that actually have their starting point in the brainstem itself. And those are pretty much mostly our medial activating system motor pathways. So that's the tecto, rubro, although rubro is part of the lateral, but mostly medial activating, reticulo and vestibulospinal tracts. Then we also have some descending pain control tracts, the cerebellospinal and the raphe-spinal tracts. Those start in the brainstem themselves. Okay, so those are brainstem originating tracts. This is just showing you some of that, what's going on here. So here's, motor tends to run down the front of the brainstem. So motor in the front and sensory in the back. Okay, so there are some exceptions, but that's a general rule that motor's running down the front, sensory down the back. Here you can see all the motor tracts are running together, especially when you're up in the midbrain here, especially this is that crus cerebri area or the cerebral peduncle area there. But then some of them stop in the brainstem. So the ones that stop in the pons are the corticopontine fibers. The ones that stop in the reticular activating or reticular formation are the cortico-reticular. The ones that stop at cranial nerve nuclei are cortical bulbar tracts. The ones that pass all the way through are the cortical spinal tracts. We're going to look at now in a sagittal section of the brainstem and then divide it into these longitudinal sections that kind of are associated with different regions or parts and where different things are. Okay? So the front part is called the basilar section. I'll try to kind of highlight. So this region right through here, all of this is kind of considered the basilar portion of the brainstem. And you have this big basilar pons sticking out here, but even the very front part of the midbrain and the front part of the medulla have a basilar portion. Primarily motor, right? Motor stuff's running down the front part of this brainstem. That's where your cortical bulbar, cortical spinal, cortical pontine, and cortical-reticular tracts are running. Then we have the tegmentum, which is this region here, this next longitudinal section, a little bit more posterior. This is where more of your sensory tracts are running. Okay, so sensory tracts are running up the back part of this tegmentum. This is where a lot of your cranial nerve nuclei are located within this tegmentum. Okay, this is where that medial longitudinal fasciculus, the one that connects the oculomotor nerves to the vestibulocochlear nerve, to the abducens and so forth, and trochlear nerves. Oh, that's the medial longitudinal fasciculus is running in there. And this is also where we have this thing called the reticular formation, which we'll get into here in a few minutes. So reticular formation is all in that tegmentum. There is also a tectum. The tectum is the roof, okay? Tegmentum's kind of the body. Basilar is the front part. Tegmentum's kind of the meat or the body of it. And then here's the roof right here. That's just your superior and inferior colliculus, just only associated with the midbrain. So that's the tectum. So those are the three kind of longitudinal sections, and you're looking at a sagittally sectioned brainstem. Okay, here's that fourth ventricle we're talking about back here, and with the and if we're looking straight down on it, when you remove that cerebellum, this floor of it is that rhomboid fossa. The floor of the fourth ventricle is that rhomboid fossa. All right, let's just do a couple of these and then we'll take a break. So the reticular formation, you keep hearing about this. Every time we go through a brainstem or talk, we hear about this reticular formation. So it's this complex, very complex neural network in the tegmentum of the brainstem, and it runs throughout the tegmentum of the brainstem. We can actually take the reticular formation itself, which is in the tegmentum, and we can actually divide it also into three longitudinal zones, but looking at it from a frontal view. Okay, kind of like we divided the cerebellum into longitudinal zones that were more functional in nature, we can do the same thing with this reticular formation that's located in the tegmentum. So here's looking at the back of the brainstem. We're looking deep into the brainstem. We're looking into the tegmentum, okay, that meat of the brainstem, and we're now looking at this thing called the reticular formation, which takes up a lot of the tegmentum, okay, and it runs all the way from the midbrain all the way down through the medulla, okay. Now we can divide it into its three different longitudinal sections, looking at it from a frontal view. So the most inner section here is the midline reticular zone, or midline reticular formation, okay? And then the next intermediate or medial reticular zone is the next one out, medial. And then we have a lateral reticular zone out here, okay? In that lateral reticular zone, we do have some significant nuclei. We have called the ventral tegmental area. It's not really a nucleus, but they go back and forth whether to call it a nucleus, but now they've called it just an area because it doesn't fully have the quite defined regions of a nucleus. So it's called the ventral tegmental area, the pedunculopontine nucleus. And then this is the locus coeruleus out here, okay? So we're going to go and talk about these regions real quick. Lateral zone, what's happening in the lateral zone? This is where you get some integration of the sensory and cortical input, okay? Information is then conveyed to the medial and midline zones. Projects to the cerebrum, cerebellum, and spinal cord. Okay, so there's regions within there that project to the cerebrum, okay, back up to the cerebrum. We have ones that project to the cerebellum. And then we have like our reticulospinal tracts that project to the spinal cord. They're important for adjusting general level of neural activity and arousal. This is also where we call this thing called a kind of reticular activating system. So when you've got motor input, sensory input, that reticular zone, that lateral reticular zone, is important for integrating that information and ramping up your arousal level based on the amount of sensory information coming in, the amount of motor output you're giving out. They influence, they have more of a general influence on movement, motor output, tonal set. It's an integrative center, kind of integrative center that regulates just excitability of your nervous system because it has these diverse and diffuse connections, okay? The medial zone, this is where you have some areas that are located specifically with some of your vital functions, okay? So those respiratory and cardiac centers that are in your pons and medulla tend to be located in that medial zone area. They project to cranial nerve nuclei and the spinal cord, some of these, because they drive the cranial nerve nuclei that are associated with respiratory function and those kind of things, and cardiac function, and then also in the spinal cord itself. They do influence posture via the reticulospinal tract, especially the medial reticulospinal tract that's in that medial reticular zone, okay? So they're influenced in the motor control of posture. And then we have the midline zone, that very center zone, mainly pain control. There's the raphe nuclei, which we've mentioned before, and there's the raphe spinal tracts that start in the raphe nuclei that go down to the dorsal horns of your spinal cord to deliver natural opiates it's a descending pain control pathway. We mentioned it we talked about the sensory system, okay, the raphe nuclei. It also is involved with adjusting levels of consciousness. Just kind of like the lateral zone is more overall neural activity, this is more level of consciousness, which they're related, but just subtly different functions. Okay? Take a break. We'll come back in 7 to 10. All right. So we're still focusing on this reticular formation area in the brainstem right now. And we divided it into those 3 longitudinal zones and talked about their main roles from a zonal kind of basis. Now we're going to go in, and remember we said there's actually some specific nuclei and regions within those different longitudinal zones. We're going to talk about more specifically those reticular nuclei and the neurotransmitters that they use to influence or drive their influence. So the first one we're going to talk about is that ventral tegmental area. Okay, remember that ventral tegmental area is part of that lateral reticular zone up in the midbrain. It's right there, right with your substantia nigra. They're separate, they're different, but they both secrete dopamine. But the ventral tegmental area is a little different region than your substantia nigra, but it is dopaminergic in nature. It influences motivation, decision making, okay? It projects, you'll see here, to this frontal region, this inferior and frontal regions of the cerebrum, and those especially prefrontal cortex. That's your decision-making types of areas of your brain, okay? It also does project to some limbic system structures, the amygdala, hippocampus, okay? And it also involves with, and this is also to the limbic system, to the cingulate gyrus, but it has strong connections with our reward centers in those limbic system areas, okay? And that's where things like amphetamines, cocaine, and so forth, those stimulate that ventral tegmental area and cause it to secrete more dopamine into those reward centers, and also gives you that sense of euphoria and high that you get from an excessive level of alertness or feeling well-being. Morphine, it has a little different action on how it influences that ventral tegmental. It actually inhibits some inhibitory connections to the ventral tegmental. So if you inhibit some inhibitory influence, you make it more active. Okay, so it releases the ventral tegmental area versus directly stimulating it like the amphetamines and cocaine do. Okay. Excessive activity of the ventral tegmental area has been implicated in like schizophrenia or true psychosis and psychotic disorders. Okay, some of the antipsychotic medications you give patients for schizophrenia involve blocking D2 receptors in the prefrontal cortex. So you have some D2 dopamine receptors, not only in the basal ganglia, but in your cerebrum. The problem is, so if you give somebody these D2 blocking, antagonist type of medications, so they block the D2 receptors in the cerebrum, but they also block some of them in the basal ganglia. So if you block the D2 receptors, which you normally are your indirect loop, you want dopamine landing on those to provide a certain level of inhibition. You want that balance between excitation and inhibition in the basal ganglia. If you block the indirect pathway in the basal ganglia, you have too much movement. So they get these dyskinesias. They're called tardive dyskinesias. They get these excessive movements with long-term use of antipsychotics. You get excessive movement because you block the indirect pathway, and then now the direct pathway is overactive in a sense because it's not being balanced by the indirect pathway. The pedunculopontine nucleus, we've talked about this nucleus as it relates to its role in influencing postural muscles and its connections with the basal ganglia. Remember, with Parkinson's disease, you not only have loss of voluntary motor activity where you've got slowness of the distal muscles and voluntary movement, bradykinesia, akinesia, but you get the rigidity because of you lose inhibitory influence over the pedunculopontine nucleus, and the pedunculopontine nucleus gets too active and turns on your muscles on both sides, your postural muscles, and you get stiff. Okay, so the pedunculopontine plays a pretty big role in that. In animals that walk on all fours, they haven't observed this as strongly in humans, but if you actually stimulate the pedunculopontine nucleus, it can actually cause a pretty good stereotypical walking pattern or walking movement, especially in like cats and animals that walk on all fours. Okay. It exerts its influence, remember, via those it has connections with your vestibulo and reticulospinal tracts, those medial activating system pathways that are to those posture and gross movement pathways. And if they're overactive all at once, they tend to cause stiffness, okay? You want a normal modulation of that. But pedunculopontine nucleus also has tracts that ascend into regions of the cerebrum and limbic system to influence other aspects of personality, and those kind of things, and limbic system function, not just pure motor. But as a physical therapist, we care more about the pure motor aspects of it. You'll notice that these regions or nuclei, that's where the cell body is. The axons project up into the cerebrum or down to the spinal cord. They help regulate large networks of neurons. Okay, so they're helping regulating they're modulators. Remember, this is where acetylcholine acts as like a neuromodulator, okay, and dopamine's a neuromodulator. Remember, these are via those G protein mediated pathways. These are causing modulation of large networks of neurons in our cerebrum, in our limbic system, in our frontal lobe, in our spinal cord, where those other fast-acting neurotransmitters like glutamate and those kind of things and GABA, those are for the individual inhibition and excitation between individual neurons. This is more influencing the excitability of large networks of neurons. Same thing with the raphe nuclei. So those raphe nuclei are located in that very midline regions, that longitudinal midline region, and they're sort of broken up. So you have some that are up here more located up into the upper pons, midbrain, then some down here more in the lower pons and upper medulla region. These are the midline zone. They project throughout the cerebrum, so you can just see super wide projections, okay, from the raphe nuclei. So the upper raphe nuclei project to these very wide regions of the cerebrum, and the lower raphe nuclei project down into the spinal cord, okay. They play a role in onset of sleep and quality of sleep is one role they play. They have a profound effect on mood, okay? So the raphe nuclei are delivering serotonin throughout your cerebrum, okay? And they also secrete serotonin at the dorsal horn for pain inhibition. So they modulate mood in the cerebrum, and they play a strong role in pain control in the spinal cord, okay? Things like Prozac is the selective serotonin reuptake inhibitor, so it prevents serotonin from being broken down, so you have serotonin that stays longer in the synaptic cleft. It has, again, more general modulation of sensory, motor, and autonomic nervous systems, and it plays that role in descending pain control. Raphe nuclei. And then lastly, the locus coeruleus, which is associated with the medial reticular zone. The locus coeruleus is in the medial reticular zone. Norepinephrine. It's secreting norepinephrine into, again, very wide regions. It's got some, locus coeruleus is here. This is a region within the medial reticular zone that also secretes norepinephrine, but to just, very diffuse regions. Most active when you need to be alert, okay? Reticular activating system. When you need to be vigilant, awake, and alert, these regions secrete extra norepinephrine to keep you alert and vigilant, okay? You even have connections between your vestibular system and your locus coeruleus in that medial reticular zone. So for example, if you have a patient who's comatose and you're trying to get them to wake up, so to speak, and you have them laying in bed, when you're lying in bed, your vestibular system's saying you're lying down. There's no reason to have your postural muscles turned on to keep yourself upright against gravity. So sometimes just getting somebody up into a sitting position is a way that you can get their nervous system and stimulate the reticular activating system. So when you sit them up, the vestibular nuclei or the vestibular system sends information to the vestibular nuclei, which then send it to the raphe nuclei, locus coeruleus, and that causes you to become more alert and wakes you up, so to speak. So we'll often work in combination, like co-treat with OT or speech. Like speech can't get the patient to be alert enough to do any participation in cognitive or feeding kind of activities, but if we get into get them up on the bedside, especially if you don't provide a lot of trunk support. If you do a tilt table, your body still knows a lot of its backside is in contact with the table, doesn't have to do a lot of work. But if you actually physically sit somebody up where you are kind of supporting them, but you can kind of like back off the support, where you make their system have to gain some control, plus their vestibular system saying I'm upright, then that oftentimes will be the first time they start to engage you or actually make eye contact or start to get some progress. So that's what you're influencing, those kind of things. These also play a role in inhibition of pain, so the descending pathways from those locus coeruleus play a role in inhibition of pain, okay? And then in the medial reticular zone, that's also where we have those cardiac and respiratory centers in the pons and medulla are associated with autonomic influence over regulation of basic heart rate and breathing. This is a similar picture to what I showed you from your Crossman book, just showing you on one side. In this case, they have all on the right side, on the right side is all sensory information, or sensory nuclei. Then on the left are mainly the motor type nuclei associated with all the cranial nerves. And we'll see when we get down in this region here, lots of stuff in here. There's still a fair amount in the middle of the pons here. All right, here we go. Now we get to go, we're going to go through more of a cross-sectional approach to the brainstem and then talk about specific lesions to the brainstem and what they lead to. So we're going to work our way up. We're going to start low and work our way high, okay? And these cross-sections are the same ones you have in your lab manual. And these are the only cross-sections that you'll be responsible for in the brainstem, okay? So, boiling it down to very general functions of the medulla. What does the medulla do? Contributes to the control of eye and head movements. It coordinates swallowing and helps regulate cardiovascular, respiratory, and visceral activity. That's about as general as you can get of what's going on in the medulla, okay? Now we'll get into some detail here. So let's talk about the internal cross-sectional anatomy of the medulla. We're going to start low. We're going to start real low in the medulla. We're going to start right here at this level, which is the decussation of the pyramids, where that crossing of the pyramids is occurring right there. So this is the horizontal section through the decussation of the pyramids. Let me change my highlighter to yellow, and let's go through these. So we're just going to, I've got the areas listed, okay? And we're going to go through and identify just in order. So B, nucleus gracilis, So nucleus gracilis is the white area. And if you remember, the way these are stained, light areas are cell bodies. Dark areas are tracts, okay? Because this is a myelin-specific stain. It stains myelin or oligodendrocytes, or just it stains the myelin on the axon. So white or lighter areas are cell bodies. Darker areas are tracts. So that's the nucleus gracilis, and then C, this area around it, is the fasciculus gracilis, right? That's coming up the back side of the brainstem. So this is front, this is back. So let me make sure we're oriented here. The back is towards the top, sorry, and the bottom is towards the front, okay? D is our fasciculus cuneatus, okay? We're not really seeing much of the nucleus cuneatus here, okay? We got to get a little higher to get to that, to see the nucleus cuneatus real well, so, okay. E, spinal tract of cranial nerve number 5. So the darker material right here, oops, I made that a little too small. That's the spinal tract of cranial nerve number 5. Okay, so the cranial nerve number 5, pain and temperature information comes in, and it goes down through the medulla, and it goes down, and that's like almost a descending track, and then it's making connections with the nucleus of cranial nerve number 5, which is this region F, and you can see how big that is. It's just this massive nucleus in there associated with cranial nerve. Okay. It's also taking in some sensory information from the back of the throat. The glossopharyngeal nerve also uses the cranial nerve number 5 spinal nucleus for processing it. So F is the nucleus. G happens to be, and this really ill-defined here, but it's just got to kind of know this region here is the posterior spinal cerebellar tract, and the region just in front of it, H, is the anterior spinal cerebellar tract. So if you had to identify that, if I circled one of these, you just have to look and make sure, hey, is it H or G for one thing, but also is there something, is there room for something to be behind it or in front of it, so to speak, to know if it's anterior, posterior spinal cerebellar tract, okay? Because I could just do it over here in this region, although typically on the spine, on the test, I will actually, I'll say identify G, it'll actually tell you exactly what to identify, okay? It's fill in the blank. You have to just like a lab practical, you just hand write it out. You'll be handwriting the names of all these, yeah. L is the pyramidal decussation. So here's the pyramids right here from the front, or from the top, or this is the front here of the medulla, and those cortical spinal tracts are coming down here, but then they're crossing over like this. They're going posterior and lateral. So they cross over in this posterior lateral fashion, and they're going back to where they're going to, in the spinal cord, they're going to become the lateral cortical spinal tract, and they sit out more in that lateral region of the spinal cord. So they're migrating to their position they're going to be in the spinal cord. Okay, but this crossing point right here is the decussation of the pyramids. The pyramids are crossing over at this point. Okay. We're too low right now. We're not quite seeing yet the decussation of the medial lemniscus. That's a little higher that occurs. Okay, this is motor tracts crossing down very low in the medulla. Okay, the pyramidal decussation. The other thing we want to look at here, O right here is a pathway. That's the spinal lemniscus, and it's kind of outlined right there. So this is the spinal lemniscus. That's pain and temperature coming up. Okay, that's already crossed over the spinal cord, but that's the spinal lemniscus, and we're going to see spinal lemniscus throughout here as we work our way up through these cross sections. So that's lower medulla at the level of the decussation of the pyramids. Now we're going to move up right here. Now we're right through the fascicula, or the cuneate nuclei and the gracile nucleus. They're going to see those really nicely here in this particular. We were a little low before to get a nice view of both of those nuclei. But we were down here in this area before. Now we're moving up in kind of the higher up in the medulla here. So this is a cross section through the medulla at the decussation of the medial lemniscus. So decussation of the medial lemniscus. So here is our nice. So we'll start with C. Here's a nice big nucleus gracilis. There's our big nucleus gracilis. And here's our nice nucleus cuneatus. We can see very prominently here now. And then we have our fasciculus gracilis and fasciculus cuneatus, which are, these axons are coming up from lower regions and they're coming over here to synapse. They're ascending and then they're synapsing in those particular nuclei. Okay? And then we have the spinal tract of cranial nerve number 5, the spinal nucleus. So again, still a very prominent feature. Here's the nucleus, and then the darker area, just a little bit lateral, is the tract. So nucleus and tract, spinal nucleus and tract of cranial nerve number 5. We still have our posterior spinal cerebellar tract and anterior spinal cerebellar tracts here. Because we're still in the medulla. We haven't gone up to the inferior cerebellar peduncle where we're going to get dumped off. We're still down low enough in the medulla that we still have these spinal cerebellar tracts because they haven't quite got up into the inferior cerebellar peduncles yet. So that's why we're seeing them right there. Okay, this is our pyramids right here, pyramidal tract. So that's our motor cortical spinal tracts coming down, down through the front of the medulla. Then we have M, which is our internal arcuate fibers. So internal arcuate fibers are these fibers that are coming from the cuneate nucleus and the gracile nucleus. So they come over and they cross midline. And they're forming here our medial lemniscus. And they're going to start to ascend now as the medial lemniscus. Does that make sense? So this is that decussation. This is the crossing of the medial lemniscus. We're at that level where those gracile and cuneate nuclei are, where the second order neuron here in this pathway is going to cross over and ascend as the medial lemniscus. But these fibers right here are called internal arcuate. They're arcing around from their location and arcing around to cross over, internal arcuate fibers. And we have our spinal lemniscus is here. Spinal lemniscus is here, J. Spinal lemniscus is here. That's pain and temperature from the body, right? Okay. Now we're going to get up into the high medulla. Okay, so we did the pyramidal decussation, medial lemniscal decussation, and now kind of more of the pontomedullary junction high medulla, or they call it at the mid-olive level. So there's the two olives we're cutting through right there. So the mid-olivary level is what this is called. And this is where it gets fun. This is where you're in that area. Remember we said where all those lovely little nuclei, the cranial nerves, tend to be situated, or a fair number of them. So let's just point out what we're seeing here. So this right here, this is the fourth ventricle right here, okay? This is that, we're right in this area here. The cerebellum has been pulled off the back, and we're seeing a little bit of the fourth ventricle here, Okay, that little, we're at the very bottom part of that rhomboid fossa, right here. That's what this opening in that area is. Okay. E, out here, that's the inferior cerebellar peduncle. That's the anterior and posterior spinocerebellar tracts are now coming together, and they've become the inferior cerebellar peduncle. We're going to go dump off into the cerebellum. Okay, inferior cerebellar peduncle. We still have our spinal tract of cranial nerve number 5 and nucleus. Now it's located in this region here and divided in half. So there's the nucleus is G and the tract is F. Okay, it's still lateral, posterior and lateral, just like it's been, you know, in these other regions as well. You know, still sitting posterior and lateral, but now the inferior cerebellar peduncle's out here, so it's not quite to the very edge. Okay. Nucleus ambiguous, H. It is somewhat ambiguous because you really don't see a well-defined nucleus there, right? So this is some of the motor that we're talking about for glossopharyngeal and vagus nerves, okay? So nucleus ambiguous. I is the spinal lemniscus. Spinal lemniscus, pain and temperature from the body, is right in this region here, so spinal lemniscus. And it's sitting still kind of, you know, here's spinal lemniscus here, sitting that more anterior and lateral. This is, eventually it's going to move more posterior. Right now we're still kind of anterior and lateral, then it's going to move a little more, still anterior and lateral, relatively speaking here, okay? M, so starting very medial. Remember we talked about how the back of the brainstem kind of flares out and opens up, and the nuclei that tend to be more medial tend to be more motor, okay, in the brainstem. Is why we, you know, in the spinal cord you have the anterior horn cells that are in the front of the spinal cord, and sensory in the back. The cranial nerve nuclei, as the brainstem kind of flares out with the cerebellum sitting back there, the more you tend to have more of a medial lateral arrangement of motor to sensory nuclei. So if you're trying to take a wild guess at something, and you're trying to decide, is that this nuclei, or is that if it's more medial, it might be probably more of a motor type nuclei. So if I'm going to guess between these couple nuclei that I've got to choose from, the motor nucleus is probably the one that's going to be more associated with that. So this is M is the hypoglossal nucleus. It's pure motor. It's the one for moving your tongue, okay? N, which is just a little more lateral, is the dorsal motor nucleus of cranial nerve number 10. That's that visceral efferent. That's the visceral efferent. That's that parasympathetic motor, parasympathetic in a sense, to drive parasympathetic control of your viscera. Dorsal motor nucleus of cranial nerve number 10. So again, we're still medial here, so we're still kind of motor arranged here, or focused. But now we start getting a little more lateral, and now we start getting more sensory type nuclei. P is the solitary nucleus. O right here is the solitary tract. There's a little tract that comes in there, bringing in information from like the vagus nerve and so forth in a tract to come up to synapse with that solitary nucleus. Okay, so solitary nucleus is that sensory nucleus that's associated with visceral sensory and taste. Okay, associated with a number of, remember this is shared by a number of cranial nerves. Okay, so that's the solitary nucleus. Q is the medial vestibular nucleus right here, Q. Its vestibular nucleus is primarily sensory, but it does have some motor connections too, because it helps contribute to some of your motor or vestibulospinal tracts, but it's, you know, bringing in a lot of sensory information here about from your vestibular system. R is the inferior vestibular nucleus right here, okay? S is your accessory cuneate nucleus. And then T, this whole area here, this is all reticular formation. Nucleus ambiguous kind of sits in a reticular formation, but this region here is that reticular formation sitting in this whole region here is the tegmentum of the medulla, but that reticular formation is kind of that meaty middle of the tegmentum there. A couple more things. You, right here and right there, is the medial longitudinal fasciculus. So medial longitudinal fasciculus. The medial longitudinal fasciculus, remember, goes down into your first few cervical segments to innervate upper back and neck muscles. Those are the ones that, remember that medial longitudinal fasciculus connects oculomotor nucleus, the abducens nucleus, trochlear nucleus, and then that goes down to neck muscles, head and neck muscles, so you're coordinating. And it's also getting input from vestibular nuclei, so that coordinates conjugate eye and head movement, okay? So the medial longitudinal fasciculus sits there. And then X is just, these are just some fibers of the hypoglossal nerve that go out to your tongue, okay? So there's little fibers in here that go out there. And then this is the inferior olivary nucleus. That's the inferior olivary nucleus. Remember, those inferior olivary nuclei project up into the cerebellum, okay? Inferior olivary nucleus receives a lot of sensory input, proprioceptive input, and processes it and sends it up to the cerebellum as well. Whew, you guys are fading. I can feel it. I can sense it. So now those are the hardest. Those are the three cross sections through the medulla where you got the most junk in there, okay? Now we're moving into the pons. So the function, just big picture. You know, I always like to know big picture first, then you can get into the details. So big picture, the pons. What's going on in the pons? Information's coming down from the cortex to the pons, and it's synapsing and some pontine nuclei that are going to send it to the cerebellum. That's where you get that copy of the motor message that goes to the cerebellum, okay? Pontine nuclei, pontine cranial nerve nuclei are associated with cranial nerve number 5, processing information from the face. So our main sensory nucleus is in the pons area for cranial nerve number 5. It also works with controlling muscles of facial expression. Cranial nerve number 7 is in the lower part of the pons, cranial nerve number 7. It also associated with lateral movement of the eye, cranial nerve number 6. The abducens nucleus is in the pons. And then the motor part of cranial nerve number 5, the motor nucleus is in the pons as well. So those are the main things that are going on in the pons. So we're going to do cross-section right through this kind of area of the pons. We're going to be above the cerebellar peduncles here, just above the cerebellar peduncles. So what we are, though, we're through where this is the superior cerebellar peduncles here, right? Superior cerebellar peduncles. So we've actually cut through the superior cerebellar peduncles, and we're looking straight down on top here. So if we look at this, you know, front is always down, and posterior or dorsal is always toward the top. But there's those inferior cerebellar peduncles we cut through. This is the cerebral aqueduct right here, okay, before it dumps into the fourth ventricle. So there's a cerebral aqueduct in here before it dumps down into this fourth ventricle. So we're looking at those areas. This is they still call it the fourth ventricle here. It's just starting to open up into the fourth ventricle. That would be like the very tippy top of the fourth ventricle as it just starts to open up and from the cerebral aqueduct to the fourth ventricle, okay? So D. D is this little region right here on this side. D is the mesencephalic nucleus of cranial nerve number 5. Remember what the mesencephalic nucleus of cranial nerve number 5 is? What it does? It's pretty small. It's associated with proprioception from the TMJ, from your temporomandibular joint. Okay, so remember where that little mesencephalic nucleus is sitting up in the pons for trigeminal nerve number 5, the mesencephalic portion of it. Actually, that's just the tip of it, because the mesencephalon is the brain midbrain, right? So this, the mesencephalic nucleus actually isn't just a specific location. It has a little bit of extension coming down, so that even though we're in the pons here, we're catching just the very bottom edge of the mesencephalic nucleus. But the trigeminal nerve nucleus, oftentimes we'll draw it like this. So it's really not three distinct structures. We don't have like just the main sensory nucleus, mesencephalic nucleus, and spinal nucleus of cranial nerve number 5. There's actually fibers and nuclei or cell bodies that this whole region is somewhat connected. So we're slicing through here, and this is the main sensory nucleus, the spinal, but once you get into this region, you're talking mesencephalic nucleus of cranial nerve number 5. But most of it is up in the midbrain. So we're seeing a little bit of the mesencephalic nucleus of cranial nerve number 5. E is the medial longitudinal fasciculus. So there's that little medial longitudinal fasciculus. It tends to sit really medial, and they're right together because it's connecting those little cranial nerve nuclei that are located really medial and right next to each other, okay? Those oculomotor nerves, those abducens nerves, okay, and trochlear. So there's an MLF right there. H, we already said, is a superior cerebellar peduncle. K is the spinal lemniscus, okay? And L and M are the medial lemniscus. Because remember, we're down in the medulla. Remember this, the medial lemniscus, after they cross over, they start in this more anterior-posterior arrangement. Then they twist and move more laterally, okay, as they go up into the pons. And they twist and get more of a medial lateral arrangement. And they go over to meet the spinal lemniscus as it's kind of progressing up and staying in that more lateral position. But now it's moving more posterior here. The spinal lemniscus has moved more posterior as it comes up, and the medial lemniscus has kind of moved from medial to anterior to posterior direction to more of a medial lateral and moved more laterally out to kind of meet it. So that is the medial lemniscus and the spinal lemniscus, that are now right next to each other. O, just the little back part of that, right, that back part there is the trigeminal lemniscus. That is some proprioception from the, I'm sorry, not proprioception, but some pain and temperature from the face, okay? That is ascending up through there, okay? So trigeminal lemniscus. P is pyramidal tracts and cortical pontine fibers. So the dark stuff is the tracts. So all this stuff is, if it's a cortical spinal tract, it's going to keep going right on down through, all the way down to the pyramids and then cross over. If it's a cortical spinal tract fiber. If it's a cortical bulbar tract fiber, what it'll do is it'll come down here and it'll make a connection with the lighter areas are cell bodies are cortical pontine nuclei. It'll make a connection with the cortical pontine nucleus, and then that'll cross over a little lower and go out the middle cerebellar peduncle into the cerebellum on the opposite side, okay? So the cortical spinal tract fibers that are running down through that go to the pyramids and down to the spinal cord are carrying the message, the motor message, to the anterior horn. But a copy of that message is being delivered to these cortical pontine nuclei that then have an axon that projects to the cerebellum, okay, and gives a deliverer the copy of that message. So Q, anything in here that's the lighter color are called cortical pontine nuclei. So all the light parts are cortical pontine nuclei. And this whole region here, this whole region is the basilar pons, that front part of the pons, the basilar pons. So you got motor tracts running down the front of that. The ones that make it through are your cortical spinal. The ones that don't are your cortical pontine, because they're sending their copy of that message to go to the opposite side of the cerebellum. All right? I think we just got one cross section in the midbrain. Yeah.
Could you point out where
where, what's that? D, E, and H. So yeah, let me just erase all the junk here real quick. D is this little lighter colored area right there on each side, okay? E is this little region right here, that little darkened region there, MLF, and then H is the inferior cerebellar peduncle on each side here. Got it? Okay. Yeah, it gets a little messy. Midbrain. So big functions, general functions of midbrain. Eye movement, cranial nerve number 3, oculomotor nerve. Relays for reflexive eye movement and head movements associated with visual auditory information, the tectum. So superior colliculus and inferior colliculus. Those are where those relay centers are for that reflex eye movement and head movement associated with auditory or visual stimulus. So this is where your pupillary, both consensual and accommodation reflexes of your eye are mediated at the midbrain, okay? So that eye constriction associated with light in your eye, and both the one that you shine it in and the opposite eye, and also the accommodation reflex where you bring your eyes in, your eye constricts a little bit, plus your curvature of your lens changes. That's all mediated at the midbrain level. That's a midbrain reflex. This is where your substantia nigra is, okay, is in your midbrain, and also that ventral tegmental area. Dopamine producing neurons. Upper extremity movement via red nucleus. The red nucleus is in there. Upper extremity flexor muscles, okay, via the rubrospinal. That's where your rubrospinal tract starts. Pedunculopontine nucleus is up in the midbrain. Locomotion and influence on postural reflexes and postural tone, okay? And then we also have pain suppression via, remember we talked about the periaqueductal gray. Also has cell bodies that project axons down to the dorsal horn to influence pain control, along with the cerebrospinal tracts and the raphe spinal tracts. They all work together in this descending pain control. The PAG, periaqueductal gray. So here's the cross section we're at through the superior colliculus. This is a cross section at the level of the superior colliculus in the midbrain. So A, the two bumps back here, superior colliculus right back there. C is, it got cut off on this side. This is the medial geniculate body. Don't really have to, yeah, I guess you should maybe know that. That's that. Remember, and the lateral geniculate body is out here. The medial geniculate body is a relay center for auditory information. Lateral geniculate body is visual, okay? D, this whole region in here, this is all reticular formation. This front part is kind of the basilar part of the midbrain. This area in here is sort of the tegmentum, with your reticular formation, and then this back here is the tectum, or the roof of the midbrain, the colliculi. E, remember now I'm going to outline this whole region here. When we get up in the midbrain, that medial lemniscus and spinal lemniscus, so in the medulla, at the crossing of decussation, the medial lemniscus was sort of in this anterior-posterior arrangement. Then it continues to kind of rotate and keep twisting as it goes up into the pons and up into the midbrain. And you're seeing it continuing to kind of rotate that way. But everything's still together here. So the spinal lemniscus stays right here at the tip of the medial lemniscus. Because remember back here, here's the spinal lemniscus and medial lemniscus, and now these have just continued, this has just kind of continued to rotate into more of this type of a position up higher in the midbrain, like that, okay? Don't worry about breaking this into G and F. That's just like upper versus lower body, because remember there's some somatotopic arrangement that is maintained in that area. H and T, this region here is the substantia nigra. It's light because those are cell bodies, but this is because this is stained for the myelin. But in a real cross section, it looks dark. It's actually dark in a true cross section. But in this case, that lighter part is the actual substantia nigra. Okay. K, this is pretty obvious. This big region right here, that's the red nucleus, rubrospinal tract starting point. N, that hole right there, that's the cerebral aqueduct. O, this whole region through here is that periaqueductal gray, the PAG. So there's cell bodies in there that have axons that project down to the spinal cord for pain control. P, little nuclei in here, most medial nuclei, a little bit back behind the oculomotor nucleus. That's the Edinger-Westphal nucleus. That's that little parasympathetic fibers that go to for constriction of your pupils, okay, that are in the oculomotor nerve. Q, on each side here, that's your oculomotor nucleus. So that's the one going to the muscles, most of the muscles of the eye, except for the abducens, abduction of the eye, and the trochlear, okay, which is the down and in, superior oblique. So this is to every other eye muscle. And then S is oculomotor nerve fibers come out right like that. This is that interpeduncular fossa region here where it comes out of the interpeduncular fossa. And then R is a dark area here, and there's a little bit here. You can't really see it, but that's where your MLF, that's the kind of the ending point, or one of the starting or ending point of your MLF, because the MLF, medial longitudinal fasciculus, connects the oculomotor, abducens, and trochlear nerve nuclei. We did not hit a section yet that showed the abducens or trochlear nerve nuclei. We missed them in all these sections. However, you are going to see a cross-section when we get into lesions that you'll see a different level of a cross-section where we actually do see the abducens nucleus and so forth. So, but we did not see, we just didn't have it in these sections. Okay. All right, let's take another 5 to 7 minutes, but we'll still finish early. Let's get back at 5 to 7. We'll make sure we're done by 11:45. All right. So disorders of the brainstem. Come on. There we go. Remember, we've talked about this before, the 4 Ds of the brainstem. If you have if you have a lesion involving the brainstem that's at least a reasonable size of a lesion, you will likely have at least one or more of these 4 Ds. It's not guaranteed, it's not 100%, but dysphagia, some difficulty with swallowing, okay? Double vision, dysmetria, incoordination essentially, or ataxia, or dysarthria, difficulty with speech that is not a motor planning, it's just like the muscles are weak and your speech sounds kind of funky because of the weakness. Other things you'll often have associated with this are vertigo, nausea. Those are other eye movement disorders or eye problems. So, but those 4 Ds are kind of just a little quick rule of thumb for you when you're looking at a patient and they complain of these. You're going, could it be brainstem dysfunction? Other common manifestations, you can, if you have damage to especially some of that reticular formation, in the pons and medulla, you can have problems with vital function. Can have trouble with their heart rate being too high baseline, too low baseline. Same thing with breathing, too high or too low, depending on how it's affected. Disorders of consciousness, okay, if you have brainstem damage, you can often, because you're damaging or impacting that reticular activating system, those nuclei or those regions that project norepinephrine and secrete norepinephrine, if you don't have those working, if you have damage there, they just have a general difficulty with arousal. However, that can be also caused by cortical lesions, so it's, again, it's not a pure 100% of the time. You also will tend to see some of these mixed signs, okay, where they might have, if the lesion is in one side of the brainstem, they can have ipsilateral motor sensory loss on the face and head, but then if you're impacting some of the tracts going through, their contralateral loss on the opposite side of the body. So you have this mixed presentation of, anytime you see a mixed presentation where one side of the body is affected, motor or sensory, and the opposite side of the face and head is affected, you're thinking brainstem. If the whole face, half of a face, whole face and body on the same side are affected, you know the lesion's got to be up in the cerebrum, okay, up above the brainstem, because everything's crossed over by that point. There are some very specific characteristic brainstem syndromes, just like we have like anterior cord syndrome or Brown-Sequard syndrome. We have certain regions of the spinal cord when damaged that cause these characteristic symptoms. Same thing with the brainstem, okay? And these tend to be associated with specific blood supplies, because the most common reason you have a brainstem problem is because of a stroke, just like in your cerebrum, strokes. And there are certain regions of blood supply that influence very specific regions of the brainstem that lead to specific deficits, okay? So we're going to go through these. So this is the cross sections you saw, but in a more of a schematic format, okay, which are a little nicer to look at, but you need to be able to know kind of both. These are much easier to look at. So this just highlights the diagrammatic black and white outlines. This is called medial medullary syndrome. Medial medullary, it's the medial aspect of the medulla. So this is the medial medullary syndrome. This is when we tend to have damage to anterior spinal artery. The anterior spinal artery comes from your from your vertebral arteries, and then goes down the front of your medulla, and we'll get that when we get to blood supply, and then it goes all the way down your spinal cord, right? And remember, we talked about anterior spinal cord, syndrome is when you damage that anterior spinal artery as well, and that causes that whole loss of the front 2/3 of your spinal cord. This area here, this supplies the front part, the medial part of your medulla, okay? We're going to just, sometimes, if you actually compress this artery, you can have bilateral involvement here. But we're going to talk about a unilateral lesion. So you might have damaged a branch of this, of the anterior spinal artery going to one side, okay? I'm going to change the color to something like green. So the deficits you're going to have with a medial medullary syndrome. Here is the pyramids. FUTL, that's face, upper thoracic, and lower body, okay, lumbar. Don't worry about that, but that's just all your pyramidal tract fibers, right? And this lesion, in this case, typically is above the level of the decussation of the pyramids, because once they decussate, they're no longer the pyramids. They're going to go become your lateral cortical spinal tract. So if you're damaging the pyramid itself, those cortical spinal tract fibers have not crossed over yet. So if you damage it here, you're actually losing function on the opposite side of your body. So you could have contralateral hemiplegia. In this case, it's just going to be of the body, okay, contralateral hemiplegia of the body. Because we're below the level of the facial nerve nucleus and all that, so, okay. So that's that part of it. Contralateral loss of position sense. This right here is medial lemniscus. V and W together is medial lemniscus. This is medial lemniscus here. This is MLF here. This is MLF over here. But medial lemniscus. This is kind of in the, where this tends to occur is more a little higher up in the medulla. And so we've already crossed over, right? When the medial lemniscus is in this arrangement, anterior to posterior, we're already above the lemniscal decussation, the decussation of the medial lemniscus. And so those information coming up has already crossed over and it gets blocked here. So we have contralateral loss of pain, not pain, position sense, okay, proprioceptive loss because of, so if we damage this, this happens to be a left-sided lesions, so they'd have right-sided loss of proprioception. So contralateral loss as relates to the lesion. The lesion's on the left, the loss of proprioception will be on the right because we're above the crossing point. And that information's coming up. It's a sensory tract. Then we'd have also ipsilateral deviation of the tongue. Here's hypoglossal nucleus right here. And it extends here into that region. And it has been blocked. Okay? So you damage the hypoglossal nerve as it exits out, but you're actually blocking the nerve itself, not a descending cortical bulbar tract that's coming down to tell it what to do. You're actually blocking the nerve, so you have ipsilateral deviation of the tongue. So because the weakness of the tongue is to be on the same side, the left side. This nerve fiber is going to the left side of the tongue. If the left side of your tongue is weak and you tell them to stick their tongue out, the right-sided muscles are going to end up pushing it over towards the left. So you have ipsilateral deviation of the tongue with this particular syndrome. I tweaked these slides a little bit, and I forgot to do it on this last slide, but actually I added in a little key for you on the opposite side here, and I updated that on the Isidore, if you saw that. But so you've got your reference here of what these different structures are. Make it a little easier on you. The next syndrome is called lateral medullary syndrome. So now lateral, we're out in the lateral regions of the medulla, and this tends to be more posterior lateral. This is a very common syndrome called Wallenberg syndrome. And it happens to do with a blockage or damage to the posterior inferior cerebellar artery. Posterior inferior cerebellar artery. And we'll get into when we get to the blood supply, you'll see all these. Right now it's not critical. Just kind of start to appreciate that artery is associated with Wallenberg syndrome. We'll show you those when we get to the blood supply. So this causes a lot of issues. This causes a lot of those Ds, those 4 Ds we were talking about. Not all of them, but some of them. You get contralateral loss of pain and temperature via the spinal lemniscus or spinal thalamic tract. So in this particular region of the body, our spinal lemniscus is right here. So you may want to change that to spinal lemniscus. Because remember, our spinal thalamic tract comes in, crosses over immediately, and then ascends in the anterolateral system, spinal thalamic tract, that becomes spinal lemniscus once you get into the brainstem. So we're causing damage here, so we're blocking signals that have come in from the opposite side of the body. Okay, so that's why we have a contralateral loss of pain and temperature in the body. Okay. But we have ipsilateral loss of pain and temperature from the face, because here's the spinal nucleus of cranial layer number 5, both the tract and nucleus. That's blocking information that's coming in from the same side of the face that comes in higher up in the pons, and it's descending first before it makes connections here. So it's blocking that information coming in from the same side of the face. Does that make sense? Because it actually comes in the trigeminal nerve, that pain and temperature, but it descends down and makes connections and synapses with that long spinal nucleus of cranial number 5, but it gets blocked on its way down because of the damage here. So that causes, this is face, ipsilateral loss of pain and temperature from the face. So contralateral body, this is, again, that mixed, so we're seeing that mixed presentation, so we know we're in brainstem. We also get some dysphagia, dysarthria in the form of kind of hoarseness, and loss of gag reflex because we've damaged the nucleus ambiguus a cranial nerve that involves cranial nerve number 9 and 10, okay? And that's this area right here, H, okay? We've also involved these contributions here, okay? So this is actually these are contributions to vagus nerve, but this is the nucleus ambiguus, which is the motor component that goes to those larynx and pharynx muscles. That's that contribution to the vagus nerve, okay? And also to glossopharyngeal nerve, to the stylopharyngeus muscle. But you damage that at nucleus ambiguus, that can lead to difficulty with swallowing. Those muscles are going to be weak, and also some of that hoarseness or dysarthria. So we've got some dysphagia, dysarthria, and loss of gag reflex. That's the efferent limb of the gag reflex. The motor efferent limb of the gag reflex is driven by that. You also are likely to have some nausea and vertigo, mainly because you've impacted the vestibular nuclei. Okay, so the vestibular nuclei here that are at this level are Q and R. Okay, we have 4 vestibular nuclei, and Christina Cooper is going to go into more depth on that, so you'll see where these are located. But at this particular cross section, you're only going to pick up 2 of them, okay, because you're a little low where they come in right now. The other one's a little higher. So you're going to pick up that Q, medial vestibular nucleus, and the inferior vestibular nucleus. So that would be these guys right here on this side. So that's going to cause nausea, vertigo, because of the difficulty with the vestibular nuclei. Okay. We're going to have ataxia, ipsilateral ataxia, because of damage to the inferior cerebellar peduncle and spinal cerebellar pathways and fibers that are coming up through that. So posterior and anterior spinal cerebellar tract are coming up through the inferior cerebellar peduncle. That's bringing information from the same side of the body. So you're going to have ipsilateral ataxia in coordination. Okay? And that's impacting all those fibers that are coming from the body that are going up in there. So it's going to be most of those are going to that lateral hemisphere of the cerebellum that are bringing up from the body and distal parts of the body. So you're going to have, some of this definite ataxia. Okay? They also might tend to veer and fall to that side because of that damage, because they just aren't aware subconsciously or unconsciously of this side of their body as much because of the damage to those spinal cerebellar pathways. The other thing they're going to have is an ipsilateral Horner syndrome. So ipsilateral Horner syndrome is because of damage to descending sympathetic pathway, the dorsal longitudinal fasciculus. And the dorsal longitudinal fasciculus just kind of runs down through here. It's a very small little tract, but it runs, and it's not, they don't ever highlight it and so exactly or circumscribe it. But the dorsal longitudinal fasciculus is that sympathetic tract that runs from the hypothalamus down through the brainstem into the spinal cord, okay? And then that dorsal longitudinal fasciculus innervates those lateral horns where you have those sympathetic preganglionic cell bodies that go to supply sympathetic control, not only your body, but it goes out and then it ascends up through your neck, the peripheral nerve, up to supply the sympathetic control of your head and face, okay? And so remember, we have we do have some vasodilation that occurs in the face, vasoconstriction that occurs in the face. Sympathetic, usually in the skin, maintains some vasoconstriction. It also causes dilation of the pupil. It helps to mediate dilation of the pupil, okay? And so, and also sweat of the face, sweat glands and so forth of the face. So we'll show you what an ipsilateral Horner syndrome is like here in a second. This is all I'm showing you here. This dorsal longitudinal fasciculus, this black dotted line that goes down through the spinal cord and innervates the sympathetic chain, sympathetic system in the spinal cord. But those first upper thoracic sympathetic neurons exit and they ascend into the cervical spine and then up through and then innervate the face and the eye muscle, eyes, and the to help for pupillary dilation, okay, and also for the sweat glands of the face and blood vessels of the face. Okay, that's how you get your sympathetic control of your head and face. But you're damaging in the medulla here the dorsal longitudinal fasciculus. So this is what you're going to see here. This is what an ipsilateral Horner syndrome here is. There's a little tiny muscle fiber called the Mueller muscle that's up in it, helps lift your eyelid up a little bit. That's got a little bit of sympathetic control to it. There's a few smooth muscle fibers in near your orbicularis oris, or not orbicularis oris, orbicularis oculi, that helps lift your eyelids. So you're going to see a little bit of eye drooping. So this eyelid's a little bit drooped because you lose some innervation, sympathetic innervation of that muscle. Your pupil is constricted because you don't have a balance between parasympathetic and sympathetic, because sympathetic maintains is for pupillary dilation, so it stays constricted because parasympathetic is the only control you have of that. So you've got constriction of the pupil. And then if it's long-standing, you might get some actual flushing and redness on one side of the face because you lose the vasoconstrictive component of sympathetic innervation of the skin, which maintains that normal amount of baseline vasoconstriction in the skin, so they vasodilate, and you get some redness and flushing in the side of the face and skin. And then they also get dry skin on that side because you lose innervation of sweat glands. So that whole constellation of signs is called a Horner syndrome. If you see that constellation of signs, you're just thinking brainstem. That's a brainstem lesion. That's the only thing that can cause that, you know. Although there are some, I take that back, there are some cancers that cause tumors out in your, like an apical part of your lung, that can influence those sympathetic fibers too after they've already come out of your spinal cord. So, but a lot of times Horner syndrome can be associated with a brainstem lesion. And it even happens in animals. This is Horner syndrome in this husky, I guess is what that dog is, that's causing his eye to be more constricted. You can see the pupil here is smaller, and the eyelid is kind of coming up like that, is drooping a little bit. So that's how you can have Horner syndrome. But you can't see obviously reddened skin or anything like that with the fur on there. Okay, so now we are out of the medulla. So we just talked about the medial and lateral syndromes of the medulla. Okay, now we're in the pons, and we have a medial pontine syndrome. So that's this region here that you see outlined, and that's because we have the basilar artery that runs up the front of the pons, but there's these we call paramedian branches that come out of that and supply that particular region of the pons, called the paramedian branches of the basilar artery. So if you have a problem or damage to that basilar artery or the paramedian branches, it can cause this medial pontine syndrome. This is a cross-section you have not seen before. This cross-section is lower in the pons than the cross-section I exposed you to earlier. So this is lower down in the pons, okay? You're actually back here is the cerebellum. This is the dentate nucleus. This is embelliform nuclei here. So cerebellum is back there. But now we're at the level of where the facial nerve nucleus is. And also we'll see the abducens nucleus as well, okay? So this is at the level of kind of facial nerve and abducens nucleus. Deficits you're going to see. If you damage a pretty good region of this front part of the pons, you damage those cortical spinal tract fibers that are running down through the front part of that pons. And they are going down to eventually cross over to the other side in the pyramids down low. Their decussation of the pyramids lower. So if the damage is up here in the pons, the damage is on the right side, the weakness is on the left. So contralateral hemiplegia. So they're going to have weakness of their arm and leg. Especially if you damage a big chunk of that, arm and leg and all that, or all through there, are going to have contralateral hemiparesis via the cortical spinal tract fibers that run down through the front part of the pons. You will have some contralateral loss of position sense and vibration because of the medial lemniscus. Here's the medial lemniscus here. Remember, in the pons, the medial lemniscus runs more of this medial lateral arrangement. Down in the medulla, when it crosses over, it's more anterior posterior, but it turns more medial lateral here, so that's the medial lemniscus. And that information has already crossed over at the decussation of the medial lemniscus in the medulla upper medulla, so it's getting blocked up here, and so that's causing contralateral loss of position sense. You will have ipsilateral lateral rectus muscle paralysis. This nucleus right here, which is situated very medial, is a motor nucleus. That's the abducens nucleus. Okay, the abducens nucleus comes out here at that pontomedullary junction, and that goes to that abducens, so you're not going to be able to deviate your eye outward. Okay, you're not going to be able to make your eye turn outward. It's not going to abduct. Ipsilaterally, on that same side, you've damaged the left nucleus and the nerve, so the abducens on the left eye, the lateral rectus muscle, I should say, on the left eye won't make your eye move out to the side. So your eye on your left side will not be able to deviate outwards. And at rest, it'll actually be sitting more adducted because it's unbalanced now. From your medial rectus will tend to pull it more inward at rest. They'll also have paralysis of conjugate gaze because here's Q, medial longitudinal fasciculus. Medial longitudinal fasciculus, so the signals that help, that medial longitudinal fasciculus allows to sync up your oculomotor, trochlear, abducens nuclei so that you can maintain conjugate gaze. So when one eye moves, the other eye follows it and is coordinated to move with it. That's all mediated by that medial longitudinal fasciculus. If you damage either side of the medial longitudinal fasciculus, you mess that up. They're probably going to have double vision, and you're going to see that their eyes are not going to track together, let alone that they have paralysis of the lateral rectus muscle. Okay? If you damage that medial longitudinal fasciculus, you're going to have difficulty with moving the eyes together in a coordinated fashion. Medial pontine syndrome. And remember, these lesions are not just this little thin little lesion that just affects, they extend up and down a little bit through the region. So lateral pontine syndrome. So now we're moving into the lateral area. We're at that same level. We're going to show you that same level of cross-section. You don't have to know this for the lab practical, this cross-sectional level. I'm not going to pull this cross-sectional level out on you. You're only going to see those actual stained cross-sections. You're not going to see this one. But you should still be aware of what's in this area for answering multiple choice questions on this kind of stuff, lesions of the brainstem. So here's lateral pontine syndrome. That's the kind of general location. It involves typically the long circumferential branches of the basilar artery. So the basilar artery sits here. We have the short paramedian branches that supply this more medial aspect. Then we have these long circumferential branches that wrap around to supply that lateral, posterior lateral portion of the pons. Yep. Okay. So what are your deficits going to be? You're going to have ataxia, and you may be unsteady and fall towards the side of the lesion. This is actually, this whole region right here, this is the middle cerebellar peduncle. This huge thing is the middle cerebellar peduncle. So cortical pontine fibers going here to deliver a message or a copy of the motor plan to that side of the cerebellum are going to be impacted. They're not going to be able to get through that middle cerebellar peduncle if it's damaged there, okay? And so you're going to have some ataxia associated with that. So it's not getting the copy of the motor message effectively to compare it to from the spinal cerebellar tracts coming up. So, and actually I should have shown this, sorry. They would actually be coming down from here, from the opposite cortical spinal tract, then crossing over to go over to the middle cerebellar peduncle. But remember, anytime you damage the cerebellum or its connections, the deficits are going to be ipsilateral, okay? So they're going to have ataxia that's going to be typically ipsilateral to the side of the lesion. So lesions on the right, in this case, they're going to have ataxia on the right, and they're going to fall towards the right side. So anytime you damage the cerebellum or its connections, ipsilateral deficits to the lesion. You're going to have some vertigo and nausea, possibly, and even possibly some deafness. You might actually impact the cochlear nerves and then also the vestibular nucleus and the cochlear nucleus, okay, or in that region. It's not here in this particular section, but remember these lesions extend up and down a little bit. You're close to it, so you might catch both the cochlear and vestibular nuclei, causing the dizziness associated with the vestibular nuclei, the deafness associated with the cochlear nucleus being involved. And that's going to be ipsilateral, right? If it's in the brainstem, it's going to be typically with that at the level of the cranial nerve or the nucleus. If the nucleus itself is involved, you're going to have ipsilateral deficits. Okay? Ipsilateral paralysis of facial muscles. This nuclei right here it's just J here. That's the facial nerve nucleus. Facial nerve is kind of wild. Facial nerve nucleus, the cell bodies start here in the nucleus, but their axons project and they go backwards. They actually wrap around the abducens nucleus before they come out and go like that. But so you damage that nucleus or the nerve here, you're going to have ipsilateral loss of facial muscles. Okay, same side, right-sided lesion, right-sided loss of facial muscle function. Ipsilateral, then also trigeminal motor nucleus, okay? So the trigeminal motor nucleus can also be influenced here. They don't show it here, but the trigeminal motor nucleus is not shown here, but it can be impacted by this type of lesion. That's where it's sitting in that general area, just a little bit, maybe just a little bit higher, just a little bit higher than that, but that lesion usually extends up a little bit higher too. Ipsilateral. If you damage the nucleus, the motor nucleus of trigeminal nerve, this is the muscles of mastication. So right-sided lesion, right-sided weakness, pterygoids, masseter temporalis. Ipsilateral Horner syndrome. This is also going to affect that dorsal longitudinal fasciculus runs through, it's going down all the way through your brainstem. So if you've got a decent lesion, it's affecting this tegmentum of anywhere in the brainstem, it can cause ipsilateral Horner syndrome, because you're going to influence those sympathetic fibers that are going up to supply your head and face, those specific functions for lifting the eyelid, dilating the pupil, sweat. It also affects your body a little bit, but your reflexes at the spinal cord level for your body, you don't notice it as much, okay? You see the effects more in the head and face because of those specific functions of the eye and so forth that are more prominent. Ipsilateral loss of pain and temperature from the face because of damage to, here's I and H, that's the spinal tract and nucleus of cranial nerve number 5. Okay, so that's when pain and temperature is coming in higher, but it's getting blocked as it comes down to make its connection. Okay, before it eventually these cross back over, go up to the other side, but we're blocking it here before it has a chance to cross over. So we get ipsilateral loss of pain and temperature from the face, but we get contralateral loss from the body. Okay, L is spinal lemniscus. Spinal lemniscus is right in here. Spinal lemniscus sitting here. Here's medial lemniscus. Remember, they're going to get really close to each other and kind of join up as you get to this region. So spinal lemniscus involved. That information's already crossed over from the other side of the body and coming up. So the lesions on the right, loss of pain and temperature for the body is going to be on the left. Here's our MLF. That MLF is still sitting here. The MLF is typically really close to the cerebral aqueduct or the fourth ventricle, and it's sitting very medial, and it's connecting, because here's our abducens nucleus. It's connecting those abducens, trochlear, and oculomotor nuclei, running up right in the center there. So that's going to cause that loss of conjugate gaze, that difficulty moving the eyes together. We're getting there. We're going to finish 11:45 no matter what. We have to finish this up at the end. But now we're moving into the midbrain. Midbrain, this is a little bit easier. Midbrain anterior lesions. So here's an anterior lesion in the midbrain. Okay, this typically is because of branches of the superior cerebellar artery being involved. Superior cerebellar artery. Contralateral hemiparesis. So this is the crus cerebri, right? This is where cortical spinal tract fibers are running down through that area, okay? Contralateral hemiparesis. And at this point, you actually probably are going to have the face contralateral involved too. You're high enough now that your corticospinal and cortical bulbar tracts are all still here together before they cross over in the pyramids or before they cross over to communicate with their cranial nerve nuclei. So this is contralateral hemiparesis, face and body most typically. This is an exception, you know, this is if it's just a very specific lesion. If it's up in the midbrain only, things have, you know, before things have they're all together there and haven't crossed over yet. So the contralateral hemiparesis. This lesion will also tend to impact oculomotor nerve, okay? The oculomotor nerve fibers will be impacted with this lesion. It will tend to catch it, and that will cause loss of a lot of your eye movement, except for you'll still have abducens and you'll still have trochlear nerve, but you won't, everything else will be knocked out. So, and it'll be ipsilateral loss. So the lesions on this case, the left eye will have very little eye movement. And then we have a midbrain tegmental lesion. So this is this central tegmental region of the midbrain. Posterior cerebral artery is what tends to be affected with this one or cause this lesion. That's what supplies that area of the midbrain. Oculomotor nerve, again, is blocked here. See, the oculomotor nerve is damaged or taken into account here with this lesion. So that's going to cause ipsilateral loss of eye movement. Contralateral loss of all sensation of the face and body. It tends to knock out this whole region, which is your medial lemniscus, spinal lemniscus, trigeminal lemniscus, all together. When you're up in the midbrain, all of those are together. Proprioception, vibration, pain and temperature, from body, face, and everything is already crossed back over to go back up at that point, up in the midbrain. So that's going to cause contralateral loss of all sensation of the face and body. So this is kind of another exception to that. You know, we talked about, you know, we often see this mixed presentation, except when you're sometimes in the midbrain, okay? In the midbrain, things sometimes are already all crossed over at that point, okay? So these lesions are a little rare. The most common lesions are going to be in that medulla, especially that lateral medullary Wallenberg syndrome we talked about. You also will have, sometimes it will impact the, actually, I should take that back. Oh, come on. Damn it. Erase. There we go. Decreased coordination and ataxia via the superior cerebellar peduncle. You can't see it here. This is the lateral. This is the medial geniculate nucleus, C, but you really can't see the superior cerebellar peduncle here. It's just a little bit deeper than this or a little bit lower than this, but this lesion will tend to impact some of the fibers coming up from the superior cerebellar peduncle. They're going to go up to the cortex. And anytime you impact connections with the cerebellum, whether it's the superior, middle, or inferior cerebellar peduncle or the actual cerebellum itself, it's going to cause ipsilateral loss of coordination. Okay, so you're going to have some ataxia and coordination deficits. You also will have some what appear to be coordination deficits in your upper extremity because of the red nucleus. The red nucleus being impacted will cause, it tends not to cause profound paralysis in the upper extremity. It tends to mediate more the flexors of the upper extremity. They have difficulty with some coordination more so when you have just purely the red nucleus involved and not the actual cortical spinal tract fibers, okay? Because they're left okay here. They're not impacted at all. Woo! That was a rough one. I'm sorry about that. That's one you're going to have to probably watch